أقول إن أنا برضه بحب أشكر الدكتور أشرف رضا والإيانا بورد على الدعوة وعلى المؤتمر يعني ساينتفك هايلي ساينتفك، وبنشكر الدكتور أحمد شوقي على الهارت فيلير كورس. It's my pleasure to introduce Professor Ahmed Shawky to discuss the diagnosis of HFpEF.
Thank you, dear professor. And I think the answer to Professor Mahmoud Hassanin's question is why don't we have amount of HFpEF patients in most registries is because we're not diagnosing them. We are missing a lot of patients because actually there are no standardized ways of diagnosing HFpEF until we got to where we are now, and this is what we're going to discuss. So it is a challenging disease. The ESC and the AACC always had this problem with HFpEF, and if you remind yourselves, the diagnosis was quite difficult to do. If you look at the 2016 and 2017 guidelines, maybe the incidence or talking about HFpEF was better in the European guidelines. In 2021, the European guidelines just put a blank. They did not even talk about HFpEF except in very small detail. When we start about heart failure, we should remind ourselves heart failure is a clinical syndrome, and we start with symptoms and signs, whatever the ejection fraction is. And actually, when you look at symptoms of heart failure, whether reduced or whether preserved, they do interact and they do have the same. Maybe there are differences in some, but if you look at this data for HFpEF versus HFrEF, you'll find that dyspnea, shortness of breath, or apnea, paroxysmal nocturnal dyspnea, maybe a little bit more in heart failure with reduced or even acute pulmonary edema, they are going on in both symptoms and signs of HFpEF. The signs of HFpEF are similar to HFrEF, except of course, because of HFrEF is mainly due to remodeling, you see a larger heart, you see a third heart sound, a little bit more common, so you do not see that in HFpEF a lot. But other symptoms and signs, including congestion, including lower limb ankle edema, it is present in both. Going on, we should look at other parameters. I'm not going to jump from the echo to what we really don't look a lot about, which are the natriuretic peptides. And natriuretic peptides, we do not believe a lot of them in heart failure with reduced ejection fraction, but in heart failure with preserved, I think this is probably one of the most important ways to diagnose a patient with heart failure and an ejection fraction which seems normal. If you look at data from TopCat, and the TopCat was including heart failure with mild reduced or mid-range as it was used to be called, and heart failure with preserved, you'll find that the heart failure diagnosis was really importantly looking at the natriuretic peptides, and elevation of the BNP over 35 or end-terminal proBNP over 125 was very helpful for diagnosing these patients because they had near normal ejection fraction. But of course, we should take care because these patients will probably have a lower than expected elevation of the end-terminal proBNP or BNP. And there are other causes of elevation like acute coronary syndromes, valvular heart disease, hypertrophic cardiomyopathy, any arterial or atrial or ventricular tachyarrhythmias. So there are lots. And actually, when we were just discussing yesterday, with atrial fibrillation, you probably will have a higher BNP cutoff point to diagnose heart failure than with the sinus rhythm. So the natriuretic peptides, don't believe them. We should believe them in heart failure with mild reduced or heart failure with preserved. But this is an important thing. Structural heart disease. When we think of structural heart disease, we think of the diastolic function, which is impaired. We think of the reversal of the E over A ratio, and actually, it doesn't make a lot of sense because this has not been shown to be accurate, and actually what should be done is more objective diastolic function. Structural heart disease in the fact not only of left ventricular hypertrophy, left ventricular mass index, the relative wall thickness, not only the size of the left atrium, but the left atrial volume index. The E over E prime, it's very simple. All or nearly all echocardiographic machines right now have tissue Doppler, so you get the E prime, and it's a very simple equation. If you have it above 9, that is significant for diastolic function. The tricuspid pressures, the peak tricuspid pressure or the pulmonary artery systolic pressure. Again, I see a lot of reports not even looking at them, and when these is measured, you can really misdiagnose if you don't measure them. Heart failure with preserved ejection fraction and pulmonary hypertension. Very important to be in consideration. So transthoracic echo is not the diastolic function over E over A ratio, it's the parameters we're discussing. And actually, we can do this very simply. Here's going for the E on the right-hand side and the E prime and just divide them by each other. And above 9 is significant, above 15, of course, is highly diagnostic. What if the patient has a normal diastolic function on echo? Actually, they have introduced a stress echo in which we are not looking at the systolic wall motion abnormalities at rest versus stress, the diastolic function at rest versus stress. And sometimes these patients at rest have a normal diastolic function or near normal diastolic function, and with stress, the E over E prime goes higher and higher. This can also be done by cardiac MRI, but cardiac MRI actually is very important to diagnose causes of HFpEF like amyloid disease and of course some sort of ischemic heart disease, but definitely it's important for those with restrictive patterns. What if the patient is not actually, in the gray area? What can we do extra than the stress test, the echo, the MRI? Actually, there is invasive testing to assess the left ventricular hemodynamics with or without exercise, and this will show us the left ventricular end diastolic pressure going up, the mean pulmonary wedge pressure, going up, and this is entailing a problem with the diastolic filling of the left ventricle. So we look at transthoracic echo, we look at stress echo in very few cases, not a lot. MRI in certain cases when you suspect there is some sort of infiltration or very rarely invasive hemodynamic assessments. But how do we put it all together? I still do not know how to diagnose. Do I do everything for every patient? Well, actually, there are two very nice scores. One score is by the Mayo Clinic, and it's called the HFpEF diagnostic score. It's very simple. H2, two things with H, heavy and hypertensive. Heavy is a patient with obese, with a body mass index over 30. That takes 2. Hypertensive is not any hypertension. Hypertension taking 2 or more antihypertensive medications. F is atrial fibrillation. And look at atrial fibrillation, it gets a score of 3, the highest. Pulmonary hypertension above 35. Elderly above 60, or a filling pressure that's the E over E prime, not the diastolic, E over A ratio, over 9, and you get a maximum of 9. You look at what the number of your patient is, and you get a probability. So let's say the patient has a number 6, score of 6. He or she probably has a 92, 93% probability of heart failure, reserved ejection fraction. The Europeans made it more intricate. They call it the PEF algorithm, and there is a score integrated into it. You start with the initial workup. You look at the symptoms and signs. You look at the ECG, the standard echo. That's what we do to our patients. Diagnostic workup on E, echocardiographic, more important findings. This is the comprehensive echocardiography, E over E prime, left atrial volume index, left ventricular mass index, and of course, natriuretic peptides, because again, they saw that not all of us really do a lot of natriuretic peptides for our patients. What if the patient is still in the gray zone? They go for the advanced workup, and then they go for exercise or invasive testing for the patient. And finally, they look for the etiology. Is it ischemic? Is it amyloid disease? Is it any other genetic problem? And then they treat accordingly. And this is the score integrated within the ESC heart failure PEF score. You can see it looks at functional, morphological, and biomarkers. 3 things. Functional, we're talking about not only the E over E prime, 15 or above is highly indicated. That's a major, criterion, and any major criterion gets 2 points. A minor criterion gets 1 point. They also look at the lateral E prime and the septal E prime, and they have cutoff points for major or minor criteria. Morphological, left atrial nut size, volume index, left ventricular mass index. And biomarkers are divided into either sinus rhythm or atrial fibrillation. You see the cutoff points are totally different. Those with atrial fibrillation have a near 3 times cutoff point those with sinus rhythm. If the patient has 5 points or more, the probability of HFpEF is very high. 2 to 4, there is a gray area, and we can go for the advanced workup. And lower than that, of course, this is not HFpEF. So a disease is very difficult to treat when you're not diagnosing it. So if you know now how to diagnose HFpEF, you might not miss a lot of patients. It seems difficult, but it's actually very simple to do. It's available in all countries, even our own. Echocardiographic parameters here are done by most machines. In fact, 90–95% of all machines. So putting it all together, you might diagnose heart failure with preserved ejection fraction and avoid misdiagnosing patients. Thank you so much.
Thank you very much, Professor Ahmed. Very challenging subject, of course. We face it every day. Why we don't have specific echo labs for diagnosing diastolic dysfunction? I know that most of the echocardiographers do the E to A ratio, but not the E to A prime and the other tissue parameters. And this is more visible than or more economic than doing the genetic peptides. Of course, it's not a substitute, but as the genetic peptide is costly and is not available in all or most of the labs. So why we don't have specific centers for echo for diagnosing this entity? Because it's very challenging.
A very good question. I agree with the old echocardiographic machines, tissue Doppler integration was not there. But I think all machines since maybe 15 years ago, I think all of them, nearly all of them have tissue Doppler. And the way to do the E over E prime is so simple. The left atrial volume index is so simple. Even if you don't have an integrated calculator inside your echo machine, you can get the parameters and just divide them by the body mass index, and it is simple. We are still, trying to do this. Again, N-terminal or BNP. BNP is a bit cheaper than N-terminal pro-BNP. I think this is correct, Professor Ahmed, because she's the one who knows all this, not more than me. And the thing is, if we ask for more patients to have these investigations, they will become more cheaper because we get more kits, because we are not asking for them. This is the same with troponin. When troponin came out, it's too expensive. It's not. And now troponin is standard of therapy or standard for diagnosis of an MI.
And the second point regarding the scores for the diagnosis. What do you use actually in your daily practice, the American or the European? Because I think that the American is more easier.
It's easier. We were discussing this with Professor Bendetti yesterday. We are not using scores exactly. We are using them in our head. And for example, if you have a patient coming with chest pain into the CCU, you're looking, he's diabetic, he's hypertensive, he has an elevated troponin, you're doing the gray score automatically in your head, but you're not getting a number, and you are, getting there. Actually, I put the ESC score because it's difficult to memorize all data. The American and Mayo Clinic score is really simple and nice. I'm putting the ESC score just on my mobile phone or just below my desk. So in patients that I suspect, I look at the score, and then I refer to anything further if I want to.
Thank you, Professor Ahmed. هو careful echocardiographer examination.
Yes.
So you can give the functional and morphological changes.
Exactly.
I have to add that the nucleotide N-terminal may be normal. Up to 30%.
Yes.
Patients with heart failure and preserved ejection fraction have normal BNP, and this is called BNP deficiency syndrome.
Yes.
ولذلك الامريكان ما حطتش النيوكليوتايدز as one of the.
This was a discussion. This is a very good discussion. And yes, some people, 25–30% will have a normal BNP. But actually, we don't want to miss the other 70%. That's the important thing.
اللي هتلاحظ في الهارت فيلير اسوشيشن الالجوريزم كاتب لك ستاندرد ايكو كارديوجرافي كومبريهنسيف ايكو كارديوجرافي. الستاندرد اللي احنا موجود في المستوصفات كلها وللاسف هو بس يمكن يدي لك 1 امبورتنت داتا يقول لك ايجكشن فراكشن لكن عايز يشخص بقى هاف باف لازم يو شود لوك فور اي كومبريهنسيف ايكو كارديوجرافي. ده اعتقد ده في سنترز يونيفرسيتيز معروفه بالاسم اللي بتعمل ديتيل تقريبا كتير على البرايم اندكس لازم تفتكر الناس كل الحاجات اللي احنا والبرايم كاس رجال دراسه. الكومنت الثاني عيان اللي بيجي بانجينا تعمل رسم قلب بيطلع بره بتطلب ستريس اي سي جي فاتس ذا سيم. عيان الهاف نيف السيمتوماتيك اون اكزرشن هتراسم هو كويس قوي اون اكزرشن بيديفلوب سيمتومز. عشان كده زي ما قال الدكتور من شويه دلوقتي اللي هو الدايستوليك ستريس تيست ممكن عيان حتى التريد ميل بتجريه وتروح منيمه على السرير وتعيد الايكو تاني وتشوف الايد على الايد برايم والتراي اسبيد اللي جاش بالرسم. اخر نقطه الدي ال بي وزي ما قلت الدكتور طارق ممكن معلش بس يمكن 30% دي كتير 20% ممكن up to 20% دي نيجاتيف. بس ده يعني خلينا نبص كوبايه مليان او 80% دي ال بي ودي بوزيتيف و20% ميبي نيجاتيف. فدي دي او ال تي 2 ستيل دايجنوستس كده دايجنوستس اوف
البوزيتيف هو ممكن يبقى نيجاتيف جروب اللي هم الناس الالبري الاوبيس السي او دي الهايبرتنسيف ده جروب ودروس بيكون له بروجنوستيك ريسك يعني الريسك بتاعهم ما يبقاش عالي. زي ما الدكتور محمود قال احنا المفروض الفيسيشن احنا الدايجنوز بتاع فين كلينيكال سندروم يعني لو الفيسيشن انا شايف ان العيان ده هارت فيلير وسبيسيفيك فراكشن ابعته اطلب البارامترز اللي انا عايزها في الايكو عشان تتعمل.